Hello dear students, welcome back to my YouTube channel Physiology Learning. In the discussion of cardiovascular system, we discussed that it will be discussed under three parts, part 1, 2 and 3. Now we have ended our part with ECG and various different series of the ECG. Now today we will be beginning with our part 2. In the part 2, the topic list already I have shown you in the beginning video itself, like the cardiovascular system introductory video. So we have the JVP, then we have the local and systemic cardiovascular regulatory mechanism, then blood pressure and its regulation, cardiac output and its regulation, then measurement of cardiac output, then cardiorespiratory changes to exercise. So this will be mostly of a regulatory part, I already told you. So this video will be on the jugular venous pressure or the jugular venous pulse. So let's try to understand what is JVP. So this JVP answers this simple question: is there a way to find out right heart failure without doing any kind of investigation? One of the simplest way is to look and observe the JVP and measure it, and then we can comment about if the patient is having any kind of right heart failure or right heart defects. So let's try to understand what is this JVP, what are the different waveforms of JVP, and what are its abnormalities. So coming to JVP, the full form, most of you might be knowing it, jugular venous pressure or jugular venous pulse. Then this is a pulse or the pressure which is measured in some vein. So that is nothing but a jugular vein. If you have your anatomical knowledge, you must have read about two jugular vein, that is the external jugular vein and internal jugular vein. Please note on this point. Many of the books or sometimes the teachers also might tell you that it is measured in external jugular vein, but it is not so, because everybody thinks that external should be outside, so it is measured in it. It's not like that. It is measured in the internal jugular vein. I will tell you what is the logic behind it. Even the internal jugular vein, the name is internal, but it is on the outer surface only. Why we are not doing it in the external jugular vein? So let's try to understand the characteristics features of external and internal jugular vein. The external jugular vein, it is actually very kinky in nature. Kinky means its course is not straight. Its course is like this. So it's not straight. So it is difficult to trace it out. Whereas internal jugular vein, it is more of a rigid vein and it is more of a straight line. So that is why we give the preference and observe it in the internal jugular vein and not in the external jugular vein. Please remember this point. Then coming to the location where it is located. Obviously the jugular vein is going to drain into the IVC, then finally SVC. So on the right side of the subject, in between the heads of the sternocleidomastoid muscle, as you can see here, the sternocleidomastoid muscle is there and we have the clavicle. There are two heads for it and the course starts in between them and it traces back and it goes till behind the mastoid process. So it generally goes in this place behind the mastoid process. So that is its location. And how do we measure it? Its measurement is usually done at an angle of 45 degrees. So what we ask the subject to do is, we ask the subject to sit in a couch which is inclined at an 45 degree and we ask the subject to turn to his left side so that the right side of the individual is exposed. This can be observed only on the right side because right side is the one where the SVC is going to be draining into the atria, that is the right atria. So the 45 degree angle is the best preferred position because that is the one wherein the vein can get exposed outside and better visible. When lying down also it's not visible. Whenever it becomes straight also it is not visible. So 45 degree angle and ask the patient to turn to his left side and you will be looking at the region of the sternocleidomastoid. So whenever we are looking at the sternocleidomastoid, most of the times the jugular venous pulse will not be visible. In a normal individual, it is not visible, or sometimes if it is visible also, it can be normal. So how do we confirm that sometimes it is visible, but how do we confirm that it is abnormal? For that, we have to do the measurement. So let's take an example how to measure it. So let's take an example that the jugular venous vein of a subject is visible till this point. Let's assume that it is visible till this point. So we have to mark a point over there. So suppose you have made the mark over here. Then after that, you will take the measurement from the sternal angle. So you will place one scale parallel to the sternal angle like this. So there will be a scale which is placed perpendicular to the sternal angle. So this is the sternal angle, and it will one scale will be placed. Another one, wherever you are locating it, you will place another scale. So you have one scale here and another scale going like this. The height between them gives the height of the jugular venous pulse. So you will place another scale wherever it is visible. And if the patient condition is severe, what will happen? The jugular venous will be visible at a much higher end, maybe just behind the mastoid process also. So its height will keep on increasing depending upon the amount of failure also. Then we have to measure the distance between these two scales in centimeters. Suppose let's assume this patient has 6 centimeters between the sternal angle scale and between the top of the jugular venous pulse. Then whether it is normal or abnormal, let's try to understand. So from the sternal angle, the right atrium, we are not placing the scale directly on the right atrium. The right atrium is somewhere deep inside. The right atrium is inside. So the usual distance between the sternal angle and the right atrium is around 5 centimeters. So whatever measurements we are getting it, we have to add 5 to it because we are calculating it from the right atrium. So the normal JVP is generally less than or equal to 9 centimeters of H2O, 9 centimeters of water. So our measurement, whatever we are measuring, in that this 5 centimeters should be included. So already 5 centimeters is included. So whatever measurement we are doing it, that should be less than or equal to 4 centimeters. Why? Because 5 centimeters is already added. So if you add 4 more to it, it is still 9, which is in the normal limit. But in our example, I told you it is 6 centimeter. So 6 plus 5 will give us 11 centimeters of H2O. In our example, it is more than 9. So obviously this patient has a raised JVP. JVP, if it is not visible, then it's fine. But if it is visible, still the measurement should be less than or equal to 9 in a normal individual. If it is more than 9, it means that there is a raised JVP. And whenever you are looking at the side of the neck, it should not be confused with a carotid pulse. Why? Carotid scores is also very close to it. So there is carotid which is pulsating and there is a JVP. So sometimes as beginners they might find it difficult and think that the carotid which is pulsating as jugular venous pulse. But how do you confirm that it's not JVP, it is a carotid? So we have to understand the differences between JVP and the carotid. There will be a lot of points I'll be telling it, but one classical point which is clinically useful, which is easier to identify the difference between a JVP and carotid, that we will deal with it first. Clinically, the JVP is better seen because it's a vein, it is better seen and not felt. It is not felt that much. But whereas a carotid, it is better felt. When you palpate it, it will be better felt and you can see the pulsations coming and going. Carotid is better felt and not seen properly. So this is one of the classical differences between a JVP and a carotid. If you go and palpate it, if it is felt very nicely, then it is a carotid, not a JVP. And there are some other differences like the JVP shows an inward type of movement, rapid inward movement, whereas the carotid shows outward movement. And the pulsation decreases by pressure at the root of the neck. Suppose if you compress at the root of the neck, the pulsations in the JVP will decrease, whereas it will not happen in case of a carotid. Then the height of JVP varies with inspiration and expiration. So the height varies with respiration and the JVP falls during an inspiration. So whenever you are inspiring, the thoracic cavity expands. There is more space for the lung to expand. So the JVP falls. The veins. So there is filling of the right atrium. So the JVP naturally falls. Then there is something called as abdominojugular reflex. And that is positive for a JVP and not a carotid. What is this abdominojugular reflex? So whenever you compress the abdomen, the veins over here will start putting pressure to the right side of the heart through the inferior vena cava, and there will be a slight rise in JVP, which will not be seen in case of a carotid. because carotid is directly coming from the aorta. So that abdominal jugular reflex, by pressing it, the rise in JVP will be seen whenever it is a JVP. So in this manner, it's easier to differentiate a JVP and a carotid. With this first classical point itself, we can differentiate between a JVP and a carotid. Once you have done it, the waveforms of the JVP can be recorded. So whenever you record the jugular pulse, there are several waves, as you can see in this diagram, it will be observed. So as you can see here, the upstroke, the waves which are upward, that is A, C and V. And two waves are coming down, which is X and Y. So let's try to understand why these waves are generated and what is the reason for these waves and what are the abnormalities in this wave. So coming to the upward stroke. So in the upward stroke, as you can see here, we have three waves. One is the A wave, C wave and V wave. So whatever the right atrium is doing, that is exactly reflected in the JVP. So whenever the right atrial pressure increases, the JVP pressure is going to increase. So let's try to understand these waves. So this is our right atrium and this is the right ventricle. And in between them, we have the tricuspid valve. And here we have the JVP. It's like the JVP is connected to the right atrium. That is why we are assessing the right side of the heart, right atrial failure, with the help of a JVP. So let's try to understand, whenever the pressure in the right atrium increases by any act, the JVP is going to increase. So let's take a condition whenever there is an atrial contraction. Suppose the right atrium is contracting. At that time, the blood is pushed here, but at the same time, there is a pressure generated which is reflected in the JVP. So when the right atrium compresses, the JVP is going to increase. That is leading on to the A wave. That is atrial. A wave indicates atrial contraction. And next, coming to the C wave. What is this C wave is? Now the right atria, by compressing it, it has emptied its blood into the ventricle. So the blood has reached the ventricle. And after that, which valve is going to close? The tricuspid is going to close. So when this valve closes, the remaining some amount of blood that generates a little pressure, which is going to be reflected in the JVP. So C, you can remember it with the mnemonic C for cusp. So we can say that it is the cusp closure, or that is nothing but it is the tricuspid valve closure. So that is what is going to happen in this C wave. So atria is compressed. After that, it is starting to relax, but because of the closure, there is a slight generation of increased pressure. So ideally, the atria would have been relaxing like this. But what happened? Because of the closure, there is a slight elevation of pressure, and after that, the atria is still relaxing. Then why is the V wave happening? The atria is relaxing. At the same time, the venous return is coming. The venous return is coming from both IVC and SVC. So when the venous return is coming and they start filling up, atria is relaxed to this much, but now we are putting more and more volume to it. So what will happen? The JVP will produce another upstroke, which is nothing but the V wave, which is nothing but venous return. One good thing about these ACV waves is it's easier to remember: A for atrial contraction, C for cusp, and V for venous return. And phenomena also: atrial contraction, it generates a pressure which is in the JVP, then closure which generates a pressure, then venous return. So these are the upward waves. Now let's talk about the downward strokes. In the downward stroke, we have the X descent and the Y descent. Atria is contracted and created an A wave. After that, atria will start to relax. So X descent is nothing but atrial relaxation. Whereas Y descent, now what has happened? Now in the venous return, the venous blood is filled, and after that, when the tricuspid opens, the blood is going to go into the ventricle and there is going to be pressure drop. So now the valve was closed here, the cuspid, the C wave was created, and after that it is getting filled. Once this valve opens, what is going to happen? The blood is going to flow into the ventricle and the pressure is going to come down from the JVP. So this is nothing but ventricular filling. Otherwise, we can say as atrial emptying. The atria is emptying into the ventricle. But now atria is not yet contracted. If it contracts, it will again create a pressure. The initial phase of atrial contraction is passive. The initial phase of ventricular filling is passive. So valve opens, the pressure drops in the atria, the pressure drops in the JVP. So atrial emptying and ventricular filling will create a wide descent. Now let's try to understand when these waves will have an abnormality. Now we have a basic understanding of its phenomena. So some of the abnormalities. Before going into the abnormalities, I want to just brief about two terms, that is stenosis and regurgitation. Stenosis means if there is a valve and there are some deposits, the valve caliber itself is reduced. The valve size, suppose there is a door and there are some things, particles which is obstructing the door. That is the stenosis. Stenosis, we can understand it like obstruction. Obstruction means completely closed, but stenosis, some gap will be there. Then regurgitation. So normally whenever a valve is there, it has various flaps. Tricuspid, so 3 flaps are there. Whenever this flap is not closing properly, suppose you have a door, if you have a, suppose let's imagine, if you have a wall through which you can enter, and if the wall size itself is reduced, because some deposition of fat or anything is happening and the wall size itself reduced, that is called obstruction. Suppose if the door, you are closing and opening the door, suppose when you are closing the door there is some gap in the door, it is not properly shutting, so that condition is called as regurgitation. So whenever the door is closed, ideally it should close completely, but right now what has happened, the door is not closed properly, so this will create some flap defect and regurgitation. So whatever blood has come, it will go through the same valve again and again. So that is regurgitation. So first abnormality is Kussmaul sign. So we saw that whenever there is an inspiration, the JVP falls. But if there is a rise in JVP during inspiration, whenever we are doing inspiration and there is a rise in JVP, then that is called as Kussmaul sign. It is also called as paradoxical rise, because normally we expect a fall, but here it is rising. This happens in pericardial tamponade condition. Next, coming to the abnormalities of AV. There are some conditions where there will be large or huge AV, or it is also called large AV. Why is the AV happening? Because of atrial contraction. Whenever there is an atrial contraction, and let's assume there is an obstruction in this tricuspid valve, now the atria will try to contract with huge force. Atria will try to push it. So naturally, the JVP will increase a lot. So this is nothing but our tricuspid stenosis. Then sometimes the A wave will be very large, which is called as cannon A wave. It is also a large A wave, but very large. When it will happen? In stenosis, there is a cannon A wave, but if there is a complete obstruction. If the tricuspid valve is completely obstructed, the atria will try to push it very hard against this obstructed wall, which will be reflected as a very large JVP, which is called as cannon A wave, very large A wave, which is called cannon A wave. That happens in tricuspid obstruction. Obstruction and stenosis. Obstruction means complete blockage. Stenosis means still some gap is left. Then there is some condition where the A wave is absent A wave. That is, A wave is not present. When does it happen? It means that the atrial contraction is not happening. When the atrial contraction will not happen? In times of atrial fibrillation. So fibrillation, we might think that the beat is more. But what actually the atria is going to do is the atria is going to shiver like this. The atria is going to shiver like this, and it's not going to compress. So until unless it is not compressing, it's not going to generate a rise in JVP. So we have atrial fibrillation. Then the CV waves, their abnormality generally happens, one abnormality, that is called CV fusion. C wave was tricuspid closure, and V wave was the return of the venous system wave. And what happens? This C and V wave, they are getting fused. Why is it so? Because whenever there is a tricuspid regurgitation, what happens is now the C wave is created by closure, but it's not closing completely. So what will happen? C wave has come a little bit, still there is some gap. Now the ventricle will try to contract. When the ventricle tries to contract, more and more blood volume will start to enter. So rather than the descent which was happening, what is happening now? Now the ventricle is getting filled from SVC, IVC, as well as from the now the atria. Sorry, now the atria is getting filled from SVC and IVC as well as from the ventricular blood. Why? Because the tricuspid is regurgitating. Valve is not closed properly, so when the ventricle contracts, more and more blood will go into the ventricle. So this will cause CV fusion. And there is another condition, that is a cardiac tamponade, which can affect the X and Y descent also. Tamponade means there is accumulation of blood or fluid around the cardiac membrane, that is the pericardial membrane, and is compressing the heart. In this condition, what will happen is there will be a deep X descent and there will be a slow Y descent. Because the heart is being compressed, the Y descent is going to be slow because the filling is going to be slow. So these are some of the abnormalities of JVP. There are a lot of abnormalities, but these are the major abnormalities and common abnormalities which you understand as a first year MBBS student. So I hope it's clear. Thank you for watching the video. We'll see you in the next video. Thank you so much.